Hi, my name is Dr. Khan Kao. I'm an emergency physician. So I'm doing the series of interviewing different specialists in the medical field. And today I have Dr. Jonathan Gutierrez joining me. Welcome, Dr. Jonathan Gutierrez. He's an emergency physician as well, and he'll be giving us a overview of the specialties and his thoughts on it. How long have you been practicing emergency medicine?
So I graduated medical school in 2012 and then did a 3-year residency. So I guess since 2012, kind of, but on my own since 2015. So almost 5 years now.
Cool, cool. And then can you briefly tell us, like, what do you do as an emergency physician?
Um, so anyone can come, as people probably know, to the ER for various complaints. And I think the biggest thing that patients don't know, maybe medical students too, is we're kind of trained more for trying to find the biggest life-threatening emergencies. Is there, like, is this abdominal pain something that's going to kill someone? And it's, in the immediate time frame. And if so, how to stabilize them, any big procedures you need to do, which specialist to call for definitive treatment, which studies to get to try to diagnose what's going on. And then if that's not happening, at least you can get a couple of diagnostic tests if necessary, and at least be able to tell them things that seem to not be going on. And then kind of just guiding them where to go after that, if they're going to go home. So
Cool.
I think that's in a nutshell.
Well, cool. Thanks for that. So a lot of us, including myself, when we were medical students, have no idea what specialty we want to go into. So how did you, or why did you choose emergency medicine?
Well, I initially went to medical school thinking I wanted to do orthopedics. And that's just because I shadowed an orthopedic doctor, two of them, for a long time in high school. But I also worked in a family practice office, and I kind of like that aspect as well, of kind of being a little more broad, versus orthopedics, and probably some other specialists are really more focused on a few things. So I kind of learned that I liked a little more variety as I went through medical school. Initially went from orthopedics, then to trauma surgery, but that's because I was at Temple University in Philadelphia. Sorry, let me turn that off. And then after trauma, thinking of maybe trauma surgery, a lot of surgeons told me that, if you can see yourself doing any other specialty, then probably you should do it, because surgery, any of the subspecialties in surgery, or if you stay with general surgery, it's a big time dedication, which is commendable. But I kind of learned that, I also wanted to have a little bit more time outside of medicine to pursue my other interests. So while I think I would have loved doing trauma surgery, I think ultimately I'm happy where I am, because I get to have the variety of different things that come into the ER. Have your, depending on how, where you work, frequent or unfrequent adrenaline rushes when, the super sick patients come in. You get to know a little bit about medicine in general, instead of kind of more focused, if you're a radiologist, you're focused more on just image reading, and they know a lot of differential diagnosis, but they obviously would get a little bit worried if they had someone come in with CPR in progress, or, I think that's probably one of the biggest things, the variety. You get to do cool procedures. Sometimes intubation is one of our biggest ones. Some vascular, like central line placements, putting chest tubes in, things like that. And then also the work flexibility. Depending on where you are in your life, you can work as much as you want or as little as you want. I know some people who do 4 or 5 shifts a month, and they're happy with that. Some people who work 19, 20 shifts a month. So it just depends on what you want to do, and also depending on where you want to be. You can live in one city like I do and work in a variety of other cities. So it has a lot of flexibility, which is nice.
Cool, cool. Thanks for that. So what kind of characteristics or qualities in a person make for a successful emergency physician, you think?
I think the biggest thing is the ability to multitask. I think that's huge, and just the ability to make mental notes about what needs to be done in that, because You can be in the middle of stabilizing someone who just came in with CPR in progress. You got return of circulation. Now you're putting in a central line, and then you get called that there's a 2-year-old coming in with shortness of breath and hypoxic. And so you try to finish up with this person as quick as you can. As you're walking into the room where the 2-year-old is, you get handed 2 EKGs to read, and overhead you get a call that the hospitalist wants the report on the patient that you paged them for an hour ago, and they're finally calling back now. So
Yeah.
you just kind of, you get that with time. So if if people who are watching this, if they're in medical school and you don't have that yet, it's so you can learn it as you go, but you just need to know that that's coming, and you just need to be comfortable with that. Kind of working under a lot of pressure. I took a few notes earlier, but I think also kind of being okay without knowing the final diagnosis. Like I said earlier, sometimes we will be able to find, this belly pain is a huge AAA that's about to rupture, but sometimes we'll have someone come in with belly pain for 3 years, and we're not going to be able to figure it out. And just kind of finding a way to, let the patient know that, we're doing what we can, but they're going to unfortunately probably need a lot more investigation than just the ER. Or even if you admit someone with, chest pain, they look like they might be an ACS early on, and, not knowing what happens when they go upstairs. Ability to speak and interact well with others. You're meeting a patient at probably the worst time in their life, and so just being able to connect with people very quickly, connect with their families, it's pretty important. So the ability to speak decently well with a variety of people from different cultures, different races, people all over the world. Definitely comfortable with lifelong learning. I think that's across medicine in general, but especially ER. You want to know, the latest and greatest of what's going on, new treatments to COVID, for example. Of course, with all of the new stuff going on, you want to learn what everyone else is learning, stay on top of things. I think those are probably the biggest things.
Cool. Thanks for that. So what do you find the most exciting about your job, or you like the most about it?
I think, again, the variety. I remember one of my friends asking me in medical school, because initially I wanted to do ortho, and he ended up doing it. He's like, don't you want to be like the biggest expert, like in shoulder surgeries, or the best person doing knees? And yeah, it'd be cool, to be known in your city as like, oh, this is the guy you want to go to for your shoulder. But I kind of learned that, I didn't want to just focus on one thing. And so I like the variety. You never know what's coming in. It can be super sick CHF patient, the next moment a foreign object in the eyeball, and just then a cold. So it's a big variety. I think I like that. What else? ER. I think ER people, other doctors, all the staff in the ER, for the most part, everyone who works there is pretty cool, easy to get along with. I like that aspect also, working with a lot of different people, a lot of fun people.
So what do you dislike most, or some of the things you dislike about the job that students should be aware of?
Some of the tough things are not so much the medicine aspect, it's more the behind the scenes stuff, namely like dealing with administrations, basically hospital administrations, corporate administrations. It can get a little, annoying, I would say, but you just kind of have to, I think any job is going to have the higher ups that kind of make things a little bit difficult, but you just have to find a way to work with others. And that's more so, like I said, not so much the medical aspect. Patients are going to, they come in with their pathology and you try to figure out what's going on, but it's more, how to get ancillary services to work more efficiently. And if you work in a place where your direct admins are kind of wanting patients to come in and out of the ER a little faster, just to help, see more patients, you got to get people out to get new people in. It's going to be difficult if radiology is taking an hour and a half just to get the patient to the CT scan, and then another hour and a half to get the CT scan read. If it's taking who knows how long for the blood to get sent to the lab and then to results get processed. So it's just little things that seem outside of your control, but there's ways that you can get involved. You can get involved in directly in hospital administration and try to work with the people above you to come up with solutions. So if you like doing that, then there's definitely ways that you can find to deal with it. Just depends on how much work you want to put in outside of just direct patient care.
Cool. Thanks for that. All right. So, what kind of ER settings have you worked in?
I've worked kind of all over, just not really rural. When I think of rural, I'm thinking like middle of nowhere, New Mexico, small hospital. I haven't done that yet. Each setting kind of has its own pluses and minuses. Like the place that I'm mainly at right now, they have a bunch of specialists on call, but it's not like the place with the Stanford residents where they have various resident subspecialties directly on call. So, at my place in El Paso, it's going to be a little bit more difficult to have, a stat ENT consult versus if you're at that place with all the residents, ENT resident can be there in a little bit, and they're a little bit more eager to learn. They're not, they don't have as much, I think, going on as the older specialists. So it's kind of some of the differences I can think of right now.
Okay, thanks. How has it shaped your work-life balance? What's the typical number of hours a physician can work per month, per year, or week? And do you guys have call schedule, things like that?
So I think the average ER doc will work about 120 hours per month. That's usually what most places consider full-time. And me, it just depended on the time after residency, how much I was working. I've worked as little as maybe 110 hours a month. I've worked as much as like 220 hours a month. It made it a little bit easier because I've found some places that do like 24-hour shifts, so I can knock out like 24 or 48 hours in a row, and then that's already a bunch of hours there. It's nice. Just like I said, the flexibility, when I initially got out, I wanted to work more, just so I could kind of refine my skills, essentially, make sure I was putting to practice what I had been learning through residency. And then I kind of cranked things up a little bit more once I decided I wanted to focus a lot on paying off med school loans and the house loan, just because I wanted to get debt free. And so I started working probably around like 210 hours a month. For a period of time, and then now that all that stuff is done,
Congrats.
Yeah, thanks. Yeah. I've kind of scaled back now to initially at the start of the year I was like maybe 110 or so, and now I'm back up to like 150. So just depends what you want to do.
Yeah, you feel like you have pretty good control of your schedule to be able to do other activities that are important to your life?
Yeah, and I do because I've stayed part-time at all the places that I'm at. That's going to be something that people who are going into this have to decide what they want to do. If you want to work at one hospital, that's fine. If you want to be full-time there, you'll just have a little bit less control of your schedule. But even then, I think you still get a decent, if you want a week off here, you can have that week off. But if you stay part-time, usually you'll be able to tell the places that you're part-time at, when do you want to work there? And then they'll see if they can fit you on their schedule. And most places are pretty good just because we're still kind of in higher demand as ER docs, fortunately. I have plenty of time if I want to go to the gym, if I want to go, target practice, if I want to go just hang out with family. I have that time, so I'm happy with it. The way I set up, month to month my schedule. If I want to set up, 2 weeks off and go, on a trip somewhere, then you have the ability to do that decently easy.
Throughout the years that you worked, how has the specialty of emergency medicine changed, as well as more recently in light of COVID-19?
I haven't seen it change too much before COVID, but I've only been in it 5 years out. I think the biggest thing with COVID is the volumes have gone down. because the volumes have gone down, that's kind of resulted in, hospitals, if they're the ones who directly employ the ER doctors, if not the corporate medical groups who contract the ER doctors, a lot of them are kind of cutting hours, just because at places where you have a lot of overlap of physician shifts, it's not needed currently, just because there's not as many people coming in. So a lot of staff, ER doctors and other staff throughout the ER are having their hours cut. So I think that's probably the biggest thing. There's less patients now, which I guess is kind of like an eye opener that a lot of patients might be having, that sometimes they don't need to come to the ER for their, pain in their finger they've had for 2 months. So I think a lot of them are starting to kind of judge a little bit more. Do they really need to go to the emergency department? I'm happy if they show up, and someone else to see, that's fine. But I think the kind of the proportion of not really high acuity to really high acuity, it's kind of changing just because overall the volumes are going down. So really when people need to go to the ER, they're kind of coming in a little bit more sick now, at least in my place. I don't know how other places are.
Yeah, I think it's similar to ours as well. What changes do you see coming to emergency medicine in 10 to 20 years?
I think the mid-level thing, I've just kind of heard on Reddit and other places that it seems like they're getting a little bit more independent, which I guess can be a good and a bad thing. It's, I've worked in places that they have PAs and Ps where they basically just, if they're comfortable seeing the patient and discharging them, you don't really see that patient, versus some places I've been at require, anyone in this age group to have to be seen by a physician at least momentarily. But overall, I think all the ones that I've worked with are pretty good about, they're a little bit, just kind of want to make sure that what I'm doing is safe. Can you go talk to the patient and see what I've done so far? So that's fine, just because, if anything, I like academics, so it almost kind of feels like an academic setting where you kind of get to oversee someone with a little bit more oversight, I guess, about how things are going, and teach them also. In terms of other things for the future, sometimes I worry, like I've heard other ER docs as well worry that, with all these new residencies popping up everywhere, essentially, who knows if the job market's going to get flooded. And so that's definitely something for people to think about, that even only 3 or 4 or 5 years from now, there's going to be a lot of ER doctors, even more than before, just because all these new residencies. And, even though all these new residencies are creating new ER doctors, unfortunately, a lot of people are still not going to want to go work in the middle of Idaho. They're going to want to live in San Francisco, New York City, Miami, Dallas, all the big places. But I've already started to see, more and more people asking, hey, have you heard if there's any jobs in this area? I can't find anything. So, it's something to look out for.
Yeah, that I think answers the question of what do you think the job market would be when the current medical students graduate. So I think it's something for them to think about, definitely for choosing a specialty, but obviously it's not the main reason to choose a specialty. So
yeah, and that's also, it kind of goes along with not just trying to get into residency, but trying to get into a place where you're going to learn well, because and just because you get into a new residency, if they're not seeing a lot of patients, it's not going to be a comfortable first few years out of residency, and being on your own is going to be a huge wake up shock. My residency, we had a decently high volume, but there was a decent amount of times where we were just so gridlocked, essentially, with boarders, meaning people that are admitted, can't get a room in the hospital, so they're stuck in the ER, and then that limits how many new people we can see. And during that time, they had not yet really come up with ways to kind of deal with that. So there were times when I wouldn't see that many patients on a shift. And at the time, you're kind of like, oh man, I get to just kick back and hang out with my friends. But if you compare that to a residency, like in the middle of the Bronx, New York, where they're just constantly seeing patients, they're going to be a lot more comfortable when they get out because they've
Hmm.
seen so many patients that now, they're already kind of ahead of you. So you definitely want to pick a place where you're going to get a good number of cases, and not just like, oh, let me just get into anywhere.
Yeah.
You can always take a year, as scary as it seems, to do like a prelim year or an
Hmm.
internal year and then apply again. Um, but I think the quality of the place is really important too, not just getting in somewhere.
I agree. I agree. What are other career opportunities you can do with, once you graduate residency from EM? So,
There's a lot of fellowships. I actually just looked right now. I don't know if it's going to take me off the screen, but I looked on the EMRA fellowship guide, and I knew about already like critical care,
hmm.
um, toxicology, ultrasound fellowships.
Hmm.
But it turns out there's also uh, there's administration, which I've heard, which is, if you kind of like being a little bit more in charge of things, you can become an emergency room director.
Hmm.
There's addiction medicine, aerospace medicine, various critical care specialties, disaster medicine, EMS. That's a big one. You kind of get to be like the EMS medical director for your area.
Yeah.
Geriatric emergency medicine. That's actually going to be huge. I think everyone kind of knows that the geriatric population is going to be growing over the next 10 to 15 years. So that could be really important because that's a whole other wealth of information. Medical education is one if you really want to get into academics full time. Pain management, palliative care, tactical medicine is pretty cool if you like that kind of
Yeah.
stuff. Um, and then wilderness medicine.
Yeah.
So there's a lot of different specialties or subspecialties that you can go into within ER, and you don't have to only practice that. That's one thing. Like I know one of the girls that I worked with in California, she did EMS fellowship, I believe, and so she was one of the new EMS medical directors for the area. But she still
Hmm.
worked in the ER just like all of us. But then on top of that, she would work with the EMS teams across the county to kind of develop new guidelines and things like that. So, and then even outside of that, you can do like festival medicines. You can get hired if you want to work at like concerts
Yeah.
or big events, sporting events. You can go international. I know a few people who've done that, worked in other countries. You just need to go through
Yeah.
the process of that. But yeah, a lot of variety opportunities.
What's the one thing that you wish you knew sooner, knowing what you know now?
Well, two things. One, it's not going to be constantly like the show ER from back in the day, where it's not just going to be constantly people coming in coding or crashing. There's going to be a lot of people who don't have primary care doctors, and so they might come in for just a medication refill, which a lot of people throughout EM have their feelings about that. That it's not the place to go for that, but sometimes we're their kind of last resort, and they don't have any other options. So um, it's not always going to be, cool, exciting, doing crazy stuff, but it can still be fun. Um, the other thing is try your best to learn everything in medical school because a lot of people, at whatever point they decide, oh, I'm going to do ER, so I just get through stuff, and when I get to my ER rotation, kill that and just learn as much as I can about ER. But if you think about it, ER is like amalgamation of everything, and so knowing what I know now, I wish I would have done that a little bit more in terms of you know the biggest kind of most serious things, presentations, pathologies in each field. um, I kind of wish I would have picked the brains a little bit more of the attendings whenever we were kind of done with rounds, etc. During lunch or whenever extra time. Can someone comes in with X, Y, or Z, can you teach me the biggest things that you think would be important for me to know about? Or asking them, 2 a.m. comes around and I have this patient, what are two or three pointers that you can give me so I can avoid calling you in the future in the middle of the night?
Yeah.
Just questions like that, trying to pick the brains of all the specialists, because the more you learn from every specialty, that's going to be a huge help in ER. So don't just focus on ER. You got to learn all the little stuff, all the other specialties as much as you can. So the more that you know about everything, the more that the better it's going to be for you. And there's going to be stuff. It's impossible to learn everything in medicine, but at least knowing references where you can look things up quickly, that's going to be a huge help. But the more you can kind of just be on your own and be comfortable with the pressure, that's going to be a huge thing. Shadow as much as you can, I think, because that's going to be a huge kind of wake up. Is this really what I want to do? So just try to work in the ER as much as you can when you're done studying, on the weekends or something. And you don't have to spend the whole day there, but a few hours just to kind of see, is this really what I want to do with any other specialty too. Kind of just verifying that you're picking the field that's right for you for the rest of your life. And,
Yeah. Are there any other resources for those who want to learn about this specialty?
I know EMRA is a good site, the Emergency Medicine Resident Association. I think as a medical student, you don't have to pay if you do, it's really, really discounted. But you can find a lot of good stuff on there. I think the other thing is, if you're at a medical school, there's probably ER residency there. So just picking like one or two attendings there that seem easy to talk to. That's going to be huge. So you can kind of pick their brains throughout the years of medical school. And then if you can meet up with, one or two residents also, that's going to be a huge thing because they can give you a lot of ins and outs of the field, answer any questions you have. And, it's probably a big resource also.
Okay, awesome. I think those are the questions I have wanted to ask you or pick your brains. So I appreciate you answering all those questions. Thank you for your definitely time to help me out and also help the medical students and any pre-med students who are interested in emergency physicians. So thank you for your time and knowledge.